Having a list of differentials at your hand is very good, because that is going to help you out in just jotting down what you can rule out at the current status, and then further move on and make out the particular plans for the patient. So you should have a clear mind what can basically result in this particular kind of unresponsive state of the individual. Cases without focal neurological signs are to be jotted down separately. Then we have the meningitis syndromes that can even mimic the condition of comatose patients. We have diseases associated with prominent focal signs. So having these focal signs give you a totally or entirely separate list of diseases. And when you don't have these focal signs, that is basically going to reveal the fact that the patient is suffering from some sort of a central causative factor that is resulting in this unresponsiveness in the patient. How do you move about, and what is the exact protocol for these patients? The comatose patients, when they present to the hospital, first of all, we're going to support the ABC, that is the airway, the breathing, and the circulation for the patient. Stabilizing the patient is the foremost duty as a physician. Then you'd provide the dextrose, thiamine, and plus minus naloxone, complete lab neuroimaging evaluation, and you would order for the EEGs as well. The neurological activity, if it is detected, conventional therapy is ordered for the patient, or you can also resort to suspect the brain death if it is following the criteria. No evidence of brain activity, mechanism of injury consistent with brain death, or basic neuroimaging consisting with brain death. So all of this is basically the criteria that has to be fulfilled for the brain death in the individual. If it is a no, you keep on looking for the diagnosis or the underlying pathological condition that is contributing towards the development of this vegetative condition. If it's a yes, and you have confirmed that the brain death has occurred in the individual, you would be looking for the confounding factors that are present: unable to perform apnea test, unknown intoxication, and limitations of the neurological examination is something that is hindering for the diagnosis in a particular way. If there is a no, then you perform an apnea test and look for whether the patient is apneic or not. And if the patient is apneic, obviously you would regard the patient as to be dead. And if he's not apneic, she's not apneic, then the patient would be regarded as an alive patient, and you would devise treatment plans accordingly for these particular patients. So this is the complete guideline when you are diagnosing the brain death in the individual. What are the protocols done? It's not that instantly you get the patient and you are going to diagnose whether he's dead or alive. You're going to follow the particular criteria, you're going to follow the particular protocol before directly documenting that the patient is brain dead. Now, if the confounding factors are present, you would look for even the nuclear scintigraphy flow scans of the brain if it is possible, and if there is a blood flow or not that is present for the individual. And again, if there is no blood flow, the patient is documented as to be dead, and you can further on follow the protocol accordingly.